Okay. Ready whenever you are, Judy. Should we wait a few more minutes?
I think maybe one more minute and you can start.
Sorry?
I think you, Raju, are you going to introduce Karina? Can she?
Yeah.
Okay. So Raju will just formally introduce you and then you can start.
Yeah, am I audible?
Yeah.
Yeah, hi Karina, welcome to the meeting. Welcome everyone. Karina has done her bachelor's in nutrition and she's finished her PhD in pediatrics back in 2020. She's working as a research nutritionist in a public hospital in Brazil, and she's experienced as a regional clinical research manager for IPEN, uh, Dr. Elena Ladas. And she's a member of the SIOP Nutrition Network steering group. Welcome, Karina. Her topic for today is use of appetite stimulants in children with cancer. And we are very excited for this topic.
Thank you, Rachel. Thank you, everybody, for the opportunity to speak today. And is my audio good? Everything okay?
Yeah, everything is good.
Great. So I'm excited to talk about a topic that I think ever since I started working with pediatric oncology is something that I get asked a lot, and I imagine that is the same for a lot of us here in this meeting as well. There is not much published about this. Surprisingly, I think it's a subject that a lot of parents and healthcare professionals ask us and talk about. So it was a little surprising how few publications there are. So this is probably going to be a short lecture, but I think it's a nice opportunity for us to discuss at the end what are our personal experiences with this kind of medication and if we are using, and I'm very interested to know everyone's experience about this. So here the problem that we are discussing is loss of appetite, which is the loss of the desire to eat, and that can frequently lead to minimized intake of nutrients and cause nutritional problems. The prevalence of this symptom in children with cancer is not widely reported in studies. I found a few studies reporting prevalences of up to 60 to 66% of this symptom during treatment. There was other studies in advanced disease reporting 25 to 54% of frequency of loss of appetite. And we know there are different factors that are going to influence in the loss of appetite in children with cancer. So that would be the tumor factors, the inflammatory cytokines, obstruction, malabsorption, other factors. There's also the treatment, I think, which is mainly what we think about when we discuss loss of appetite. We think about the treatment-related symptoms, so dry mouth, mucositis, nausea, and vomiting, side effects overall, but there are also patient factors that I think are very important issue in this case, like pain, like food aversions that are developed during this time, anxiety during eating, stressful situations that are created around mealtime, and even depression. So appetite stimulants are substances that increase a person's appetite. Usually they are medications that were developed for something else and or were being studied for something else. And then somehow they discovered that one of the side effects was just increase of the person's appetite. So the most studied ones are magistrate acetate, ciproheptadine, and there are some others that we are gonna discuss on the course of this lecture. About frequency of use of these medications.
Karina?
Yes,
Karina,
sorry.
sorry. Now you stay on the first, I can only see the first slide.
Oh, you
I don't know,
didn't.
did you move on? Yeah.
Oh, I am moving slides. Yeah. Are you in the title or in the loss of appetite?
We can see the first slide, and then on the side we can see the next ones. Amy suggested you try to go to speaker. What did Amy suggest?
Wait, let
Presenter
me
mode,
see.
if you can.
On Zoom, you mean?
I think on PowerPoint. If you go to the top of your screen, see if you can, if you go to presenting view.
I am in presenting view. You can see the presenting view, only the slides.
Okay, now we can see the next one. Okay, so it happened last time
Oh,
as
okay.
well. Don't worry.
Okay,
Okay.
is it
All right.
full screen
Yeah.
now?
No, it's not full screen, but we
Oh,
can at
that's
least see the
weird.
next slide.
Oh,
It
why
happened
is
last
that? Okay,
last time
yeah,
as well. Okay.
it's full
Thanks.
screen for
Sorry.
me. Well, it's
Sorry,
okay.
Karina. Okay.
No problem, no problem. If there are any problems, let me know. Okay, so the frequency of use of appetite stimulants is not usually reported in studies. I could only find one solid tumor study from the US reporting 56% of the patients using appetite stimulants, but they considered metoclopramide as one appetite stimulant, which I don't think a lot of us would consider this medication under this category. So it's a little unclear. Did the slide change to evidence in adults, just to check? Or no?
No, it's still in the appetite stimulant slide.
Oh God, that is so weird. I'm gonna stop sharing and share again. I'm sorry,
And
everybody.
now it's okay. Oh,
Yeah, oh, sorry. Was it in full screen though?
No. So I
No.
think, yeah, let's start,
Yeah,
try
let's
again.
try
And then
again.
we can just go on.
Yeah. Let me see.
Yeah, I think we can
Yeah,
see the
it's
next.
still not, yeah, but it's still not in full screen, right? That's so strange. Well, okay.
Have you got more than one screen, Karina?
No,
Like two computer screens?
no, just the
Okay.
one. Yeah. Don't know what's up. Well, okay.
Okay, now we'll try to figure it out because you're not the first one it happened. So
Yeah.
just go on.
At least I found a way I can see my own screen sharing, so I'm gonna keep that in mind so I know if the slides changed or not. So there is some evidence in adults overall about the use of appetite stimulants, mainly for use in anorexia, cachexia, for cancer and HIV patients, usually showing some increase in weight and appetite, but no improvement in quality of life. Ciproheptadine is mostly used for kids, but there are some studies in adults saying that it can promote weight gain and increased energy intake in some populations. But it didn't stop weight loss in advanced cancer, and there's almost no information on body composition. There have been some studies with melatonin, but it didn't show a benefit for appetite, weight, or quality of life in adults. Some corticosteroids have been used for this purpose, showing it increases appetite and weight, similar to medistrel acetate, but with more toxicity. So they recommend the use only for short term. Anamorelin has been studied. It's a norogrelin mimetic and increases appetite, but apparently no, it doesn't increase lean tissue. Dronabinol and cannabinoids have been studied in this population as well. but it didn't show as effective in appetite and weight gain. And it's not changing again, sorry. Okay, I'm gonna do this. So the evidence in children, but in other pathologies than cancer, this has been studied in the context of feeding difficulties, showing that cyproheptadine improved patients' weight and eating behaviors, but body composition wasn't studied. For undernourished kids, it's been shown to increase weight and BMI, improved less early satiety, and improved growth. This is cyproheptadine. For cystic fibrosis, cyproheptadine has been shown to improve weight and BMI as well as appetite, but it showed increased fat mass, and there were some adverse effects that could worsen cystic fibrosis, so they don't recommend the use. For other chronic medical conditions, cyproheptadine has been shown to increase weight for different pathologies such as asthma and tuberculous meningitis, and improvement in appetite. But what about children with cancer? So I'm going to show some of the studies that I found through a systematic review on this topic that I'm working on with a student. So these are some of the studies that we found, actually all of them that we found, it's only a few. So this one from 2003, it's a retrospective chart review of children treated with magistrate acetate for more than 30 days. So they analyzed these 19 kids, and they saw after 3 to 6 weeks, there was weight gain and increase of caloric intake and on appetite score. They didn't see any improvement in quality of life scores or linear growth. And they realized that the weight loss after they stopped the medication, the children started to lose weight again. And what caught everyone's attention was that 92% of those kids presented with extremely low cortisol levels. So that can be something very dangerous. There was one adrenal suppression. They think that there was a magistrate acetate related adrenal suppression playing a role in one acute life-threatening episode. So this is something that just set the authors to say this medication should be used with extreme caution. This other study from 2008 with cyproheptadine studied in children with diagnosis of cachexia secondary to cancer or cancer treatment. So children that had a positive response to cyproheptadine were evaluated at 8 weeks and stopped. And the ones that had a negative response continued for 4 more weeks with magistrate acetate. That was 66 kids, and 73% using cyproheptadine gained weight, and 3% of them maintained and increased. There was an increase in leptin levels. They didn't see a variation by age group, but saw a better response in hematological malignancies. And there was no serious adverse effects. Usually for pediatric oncology, it's not reported, the serious effects for cyproheptadine. The most common ones are drowsiness, headache, insomnia, and dry mouth. And those 6 kids who went on magistrate acetate, out of them, 83% maintained or gained weight. This is a study from Turkey from 2014 who looked retrospectively at 14 patients who used cyproheptadine. So they saw 4 in 8 weeks after intervention and saw an increased mean weight for age Z-score for those patients, and there were no significant adverse effects or toxicities. In this other study from 2014, children that were in cancer treatment and that lost over 5% of their weight or had anorexia received magistrate acetate for 90 days. In this study, they looked at body composition, including measurements of DEXA. So that was 26 patients. It was a randomized double-blind placebo-controlled trial, and 13 patients received magistrate acetate and 13 placebo. For the magistrate acetate group, they saw an increase in weight, so 19.7% versus placebo that lost 1.2%. And they also saw increase in weight for age, BMI for age, and MUAC for those patients. And they saw through DEXA an increased percent of fat mass Z-score, and 6 of the 9 patients that were studied maintained or lost lean body mass. In this other study from 2019 that was studying melatonin to determine the safety and tolerability of escalating doses, they saw as a side effect that the children gained weight. 7 of 9 patients had gained weight. So they thought this could potentially be an appetite stimulant, maybe it could be studied in this population. It looks like it's safe to move to testing in a larger number of patients. But currently there's no really a lot of evidence to support anything so far. And I found 2 studies about the use of medical marijuana in children, adolescents, and young adults. This is one from a single center. It's just a survey, so they surveyed 50 patients from 7 to 21 years old. 80% of them reported a high level of general satisfaction using cannabis, and 84% reported a benefit for nausea and vomiting, and 70% for appetite improvement. And in this other survey with 66 patients, 15 to 24 years old, 32% were using cannabinoids during cancer treatment in different presentations. 24% reported benefit for nausea, and 48% reported appetite improvement. But none of these studies looked at weight gain or appetite scores per se, or body composition. So these are all the studies that we could find for pediatric oncology. I think there are some important conclusions and considerations that we should take into account, in my opinion, when discussing this subject. I think the evidence supporting the use of appetite stimulants is not consistent, and there are very few studies so far. I think clinical outcomes need to be studied. I haven't seen any studies measuring any impact really in clinical outcomes using those agents. There's also no shown improvement in quality of life. So even if some studies report an increased appetite and even intake of calories, how is that really going to be impactful in a patient's overall quality of life? Body composition is very little study, so we don't know a lot about the quantity, and even little about the quality of the weight gain when there is weight gain. So we need more research to know how these substances can really impact on that and promote weight gain that has quality, that they're not losing lean mass and they're not gaining excessive fat mass. The studies are very heterogeneous in terms of diagnosis and moments of treatment. The samples are very small. So it's very hard to really tell what's going on. From the magistrate acetate studies that we've seen, it could increase appetite. It does in a lot of studies. There are some modest effects on weight gain. However, from this one study, we've seen there was a disproportionate increase in fat accrual and an increased risk of adrenal suppression that comes from other studies as well. So this can be a risky one to use. Cyproheptadine has been evaluated for weight gain, but there have been no randomized clinical trials performed in pediatric oncology so far. So and no studies of body composition in more detail. So I think we need more information on that too. And for cannabinoids, there's only been surveys so far, no nutritional status information. It really needs to be studied in more detail if this is to be considered as an appetite stimulant to be used in this population. I think overall, I haven't really used this kind of medication in my clinical practice, but I think I've heard of other institutions that do. And I think it could be mainly about adjusting expectations if you decide to use it, because we really don't know if the outcomes are really going to be impactful for that child's well-being and for their treatment. So this is my personal opinion on this. I want to thank you for your attention and just open this topic for discussion and for everyone to share their own experience. Thank you very much.
Thanks, Karina. Wonderful session. Any questions from the audience? Any questions, any comments if anybody is using appetite stimulants in their institution? It will be a good discussion.
Jeremy's hand is up.
Hey, Karina, great talk. Yeah, it's such a conundrum. And, I think even in my practice here at my institution, I think we use cyproheptadine probably by far the most. But we'll hold it during cycles of chemotherapy because the kids may not have a good appetite at all, or maybe nauseous, and so sort of making them feel hungry when they're having vomiting seems kind of cruel. But I often think we're treating more ourselves than the child, because we see we'll have these sort of metrics on their chart that show that they're 2 standard deviations below for their weight or weight for height, and so it will sort of jump out at us that there's a problem, but may not necessarily be like, I don't know if appetite stimulants are the answer or not, and I think that's what your data showed. So I guess my question, it's not just for you, Karina, because I don't want to put you on the spot, but for the whole group. But if one had the resources to design a clinical trial on appetite stimulants, what would be some of the key things that we would include, some of the key things that we would control for, how we may randomize patients, how we may select patients, like which patients may get the most benefit. So just be curious to hear everyone's thoughts on how we would approach this systematically if we had unlimited funding.
That's a great question, Jeremy. I think it would have to be something very well thought about. One thing that comes to mind is from that, there was one study that saw a big difference between hematological tumors and solid tumors. So I think that's one thing, to maybe focus on one of these groups or have a big enough sample that you could analyze them separately. Yeah, I think that would be one thing. I would definitely include DEXA to look at body composition if available. That's for sure something that is very important to us, and definitely clinical outcomes, because I don't think I've seen it measured in the impact measured in any study so far. I don't know if anyone has any other ideas.
So Karina, I think like back before 5 or 8 years back, with Dr. Brijesh Arora, I used the appetite stimulant of megesterol for a patient, and just want to share that the patient was an adolescent, but we actually found an increase in the blood sugar level. So that would also be one good criteria to look at if at all we are planning for a study. But of course there are no clinical trials, so we cannot really use it for a group. So I mean, we can't really use it for all of us, for all patients, routinely.
Yeah.
Yeah, I think I don't know how you would necessarily add this to a study, but I think one of the things that in my clinical practice that I see that myself and other providers is at what point do you abandon appetite stimulants and go to enteral feeds, whether it's an NG tube or a G tube or something like that. Because I think one of the concerns that we see sort of clinically is we start to worry about toxicity of chemotherapy and things like that. But again, these are a lot of unknowns, as many of us here have been working on a systematic review recently, and we all know that the real lack of literature here in this area. But yeah, at some point, I wonder, if there are certain criteria at which we say appetite stimulants aren't working, we need to try, either enteral nutrition or parenteral nutrition. Yeah, I don't know the answer to that, but that would be something I would love to have answered through a clinical trial.
Can I comment? What impresses me, and that's not only for this topic, but for many, is there's so little evidence. And as you say, if you say, what do we need to decide whether we start either appetite stimulant or enteral nutrition via tube, NG tube, for example? At least for NG tube, there is some evidence. And for the appetite stimulants, there is what is shown here. I don't know the literature, but it's shown here, there's no evidence at all. And what worries me the most is that if there is some evidence, it's about including the DEXA scans. It shows that the percentage of fat mass increases and not the percentage of lean body mass. So I'm very worried about using these kind of drugs for which we don't know anything. And I would favor, if there's a thought that it works, then we should collaborate and find money to do a randomized control trial, and then at least do a proper power calculation, because a randomized control trial of 26 patients, it's useless. Well, it's too harsh, but not of very much value. And then at least include some kind of DEXA scan or body composition measurement at least.
Yeah, I agree. This needs to be more studied. If a lot of institutions are still using them, and some people report that it does increase appetite and kids gain weight, but that's the thing, we don't know what weight is that.
Yeah, and of course that's okay. And so if we believe in things, we do believe in a lot of things. Mm-hmm. But if it's true, and let's be honest, in a lot of other medication, there's no randomized controlled trials as well, and we still use it. But nevertheless, if we start, this is new, so it's in the modern era. If you start using these drugs and we have the feeling that it works, and I think we are obliged to the kids to at least try if it works, see if it works, and prove if it works.
Exactly.
Karina, did any of the studies actually, when they've noted an increase in appetite and the fat mass gain, did any of them make any kind of analysis on actual dietary intake? Because it's all very well stimulating appetite, but if you're stimulating appetite and maybe the wrong food choices are being made, the sort of role of that on fat gain, did any of them look at that at all?
I think one or two looked at calories intake or improved intake overall, but not at quality. So I think that's a very important point, because then you can't just give the appetite stimulants also and not have a nutritional guidance to go with it. Then what are those kids eating? And maybe that's why they are gaining too much fat from that. So that is very important as well. Good point.
Did any of them use the appetite stimulants on children that were being enterally fed?
I don't remember seeing that. I'm not sure. Probably not. There are not a lot of details on those studies on most of them.
Just in terms of their function, do they sorry, asking so many questions. Do they stimulate like gastric transit, or is it just stimulating the sort of appetite desire? How do they actually function?
Oh, that's a good question. I don't know. Yeah, I'm not sure actually.
Yeah, no worries.
Does anybody know that, how the mechanism of those medications?
So good.
Yeah.
That can be a next
Question.
project, maybe.
Yeah.
There was a lady in the chat that said she wanted to ask a question. Neda, you can ask, please.
Hi, thank you for this nice presentation. May I ask a question about olanzapine? Is there any published data support its use, and from your clinical experience, do you recommend it?
I'm sorry, I didn't understand. What drug?
Olanzapine, which is a typical antipsychotic used in adult cancers, sometimes to improve appetite and improve sleep. In pediatric oncology, do you have any published data about its use in pediatric cancer?
If there is, I haven't found it. Looking for this topic, I haven't seen anything. I don't know if anyone knows of another study.
I do know the studies about using it for anti-nausea.
Hmm.
I don't know, but don't
So-
know the part, but that's the way it is studied and even recommended.
Okay, thank you.
Does anyone else have experience on clinical practice using one of these medications?
Hilda, you can ask. Hilda's hand is up.
I think Dr. Kellerman has raised her hand.
Oh, she seems like she can't unmute herself.
Oh. Do you want to write your question or comment?
Hi, can you guys hear me now?
Yes,
yeah.
we can.
Yeah.
Oh, fantastic. Thank you very much for that. Thank you for such an interesting presentation. I really enjoyed it, and it's made me think a lot about some of the things that we've observed when we did a little bit of research, also with Judy's study. And we've seen, so I don't have any like exposure to using these kinds of drugs, but what we have noticed was that the body composition and overall anthropometrics react so quickly to the introduction of chemotherapy. And just when we link that to the conversation that we've had thus far in terms of, using nasogastric tubes or sort of other nutritional ways of boosting intake and trying to sort of prevent weight loss, I would actually think that it would be a little bit more prudent to rather be faster in terms of introducing a different method of boosting adequate intake than to just wait for an appetite stimulant to sort of kick in and work, especially since we're not sure how it works. And then I was also thinking that some of the literature that you've mentioned there, it actually says that the sort of like the average age is 11 and 12 years old, some of the kids. And thinking about this recommendation now that I've seen, we found that using a nasogastric support or a nasogastric feeds works so well. But it is interesting that kids 11 and 12 years old, if they've got a choice, they'll never choose a nasogastric, I don't think. Until they actually see like, wow, okay, I don't have to stress as much, I don't have to eat as much, this tube is actually working in my favor, then they sort of accept it. But I find that using the nasogastric with the smaller children is a lot easier. So that's just something interesting that you could note potentially.
Yeah, I agree. It is easier for smaller kids to do enteral nutrition, in my experience as well. Any other comment? Oh,
Karina, when's your
Carmen?
systematic
Go
review
ahead.
due to come out? When's your systematic review due to come out?
Oh, not sure. I have to check with my student how she's doing. But
And what
yeah, we
is
would
it
like
like?
to write it up
Carmen,
soon.
Carmen Soto's hand is up. Please go ahead.
Hi, thank you for the talk. I think I was just going to reflect that while the numbers are what we're chasing, it's ultimately the impact on the treatment journey that's important, right? And I don't think any of these studies actually take that into consideration. So we're looking at things like, what their infection risk is, how neutropenic they become, treatment delays, how often are they going to school? Ultimately, that's what we're trying to chase, not the numbers on the scale or the percentage body fat. And I think I get that it's tricky, but I think if we're talking about as a group as doing longer term research into this area, then those are the outcomes we need to be looking at, right? Not so much whether one number jumps from one percentile to the other, but actually what is the impact on the child?
Yeah, I completely agree. There are some very, very important variables that haven't been looked at.
Yeah, I agree. I think body composition is something that definitely needs to be looked at. If the studies is ever considered, I think we have definitely well thought of everything that we need to look at. And yeah, I've compared it with just normal, I don't know, ways to improve appetite and see what's the difference. Is there any other questions from anybody?
Yeah, I think this was a pretty short and a sweet topic to wrap up early. So, thank you, Karina. I think we can conclude here.
Thank you.
Thank you so much for a fantastic talk. Thank you, everyone. And we would meet on the next schedule. We would meet on the next schedule next month in April, and end of the week. Yeah.
Yeah, end of the month.
End of the month. Yeah.
Okay.
Thank you, everyone.
Thank you.
Great. Bye, everybody.
Bye.
Bye.